At the College of Education, I have a great pleasure to welcome all of you to the second day of Essentials of Health Informatics program. Our program today will start with 2 public lectures. The first one is about the status of health informatics in Saudi Arabia, and the second one is about Saudi Arabia, e-health and health IT standards. At 12 o'clock, we will have a break, a 30 minutes break, coffee and prayer. Then we will have the official ceremony starting at 12:30. Then after that, we will have an overview about the 10 by 10 course. Our first lecture today, without any further delays, because we're supposed to start 9, we'll start with the title of Status of Health Informatics in Saudi Arabia. This lecture will be delivered by Mr. Russell Gan, one of the distinguished speakers. Mr. Gan just recently left the Ministry of Health, serving as the Surveillance Coordinator, Medical Informatics Lead, and Program Manager for the Kingdom of Saudi Arabia Public Health Directorate. He has broad education, training, and over 30 years of experience in the U.S. and abroad in developing, managing, implementing, evaluating, and improving informatics development assistance projects, and advising the U.S. government, United Nations agencies, World Health Organizations, and national public and private health sector counterparts on various aspects of surveillance, science, and health services research, and on assessing and improving the policies and practice of public health monitoring and evaluation and logistics management. He was also Chief of Medical Informatics Officer during the H1N1 outbreak and continued in this task until he left the CDC in 2011. He architected the International Healthcare Safety Network, which is abbreviated as IHSN, for the Saudi Arabia National Guard, and assisted in the configuration, training, validation, and development. Please welcome Mr. Russell Gan.
Thank you. Good morning. Oh, I had my cup of coffee, so I think I'm good. So I'm going to talk to you a little bit about the last 3 years and possibly some of the history of what has gone on just prior to that, based on the discussion that you've already heard. Let me see if this is working. There, okay. All right, so just briefly, the agenda. We're talking about a little bit of the history of what's gone on. I want to give you an idea of surveillance and what it means to me. We're going to talk about the e-health strategy, but only briefly as it pertains to what we're doing here. Now, what you're going to get this afternoon from Dr. Ahmad Belkhair is a much more in-depth presentation regarding this and exactly what's happening today. We'll talk about the Saudi CDC that is still in its infancy, about HESN, the Saudi National Healthcare Safety Network, and then I'll summarize at the end. I'm assuming that the questions are going to be held at the end, but I have no issue. Are we good? Okay. So, a little bit about my history. I've been working in IT as well as biostatistics and surveillance for about 30 years. I've been in numerous places. I started out as a combat medic. Once I actually didn't have to do any work as a combat medic, I became a paramedic in the state of California in the U.S. For a number of years I did this until I actually was able to challenge and become an RN for the state of California. And so I became a nurse paramedic. And then briefly, I spent time doing that. I went into one of the very first certification classes at Stanford University to become a physician's assistant in emergency medicine. And not too long after that, I actually burned out on medicine completely. I couldn't do it anymore. I couldn't think about it. So I went completely into IT And this bridge that I've been on is actually coming together over the last couple of years. I think I'm doing this. Let's see.
Now you're on video.
Uh-oh.
Maybe you're taking wrong.
I thought I was going up. Whoa. All right. Well, that looks different.
If you want, you can move from here.
Okay.
That's better. So you can.
I can use the keyboard here.
Yes,
Okay.
let me-
All right, so are we okay? So I spent approximately 10 years, from 1997, I became a contractor there, and then I spent a good bit of time working as a contractor before I became an actual employee. During that time, I was the Associate Director for Technology and Informatics for the National Center for Public Health Informatics. I was the program manager for infectious disease alerting system called BioSense. We actually took the pulse of the nation through a messaging... Whoa. I didn't touch anything, I swear. All right, we'll get there. So, I was also the program manager for infection control, the National Healthcare Safety Network. This means that I had managerial control over the architecture, over the budget, over all design work, updates, upgrades, changes in definition. And so, subsequent to that, I also had program management responsibility over FINVADS, which is our vocabulary definition database that we use at the CDC. I worked as the informatics technical lead for H1N1. When the outbreak occurred, I was actually heading to California to a wedding. When they actually stopped the plane, I had to get off and go back to work so that we could spend the next 3 to 5 weeks sequestered in a building to try and prepare for what turned out to just be H1N1. You get the flu, you feel like you're going to die. This was kind of the same thing. But we had to be prepared. At the CDC, that's what we do. So I also, during that time, was asked to do a version of our National Healthcare Safety Network for the National Guard. I worked at the CDC with Dr. Robert Fagan, putting together the architecture for this application, the way it would work here in the kingdom, without a full understanding as to what was required here. I didn't know the requirements. I didn't know the infrastructure limitations. National Guard had 4 hospitals. My assumption was that they had everything that they needed. So, after that, I came to join the Ministry of Health. I thought I was going to the National Guard, but it turns out that my boss, Dr. Mimish, had been promoted. So instead of going to the National Guard, I ended up coming to the Ministry of Health. And so I worked for my first year here as a project manager for Hessen. With the help of many people, we implemented the Healthcare Electronic Safety Network in Jeddah, Taif, Mecca, and Kunfada over that time. We had to do a number of configuration management meetings. We had to talk with stakeholders, with SMEs in numerous areas, and when it was all said and done, the implementation was done there. I was project manager for NHSN. We've actually put together a copy of the application used at the CDC, very similar to what's used at the Saudi Arabia National Guard. And I've been project manager and trainer for numerous other informatics projects and statistics. I teach SPSS, I teach SAS, I teach biostatistics. I teach courses in surveillance, and I teach courses in evidence-based medicine. So I've had a lot of background in a number of things. I also write on journal articles for WHO. I've written a number of papers for AFINET, which is the North Africa, it's actually the African Epidemiology Network. And you can probably find a number of my journal articles if you look it up at CDC. But the key reason that I was brought here is actually the first item on this list. And that was to be the informatics and technical project lead for the Saudi CDC. The Saudi CDC actually is our effort at bringing together the electronic surveillance network, the National Healthcare Safety Network, and anything that we can get from the non-communicable disease areas as well. We've got many registries out there. Diabetes, we've got osteoporosis, we've got a number of things that are occurring within the Ministry of Health. Excuse me. Okay. So surveillance. What is surveillance? The ongoing systematic collection and analysis of data and the provision of this information that leads to an action. It's got to lead to an action that's taken to prevent and control diseases, control infections. So this is what we're here for. We're here to save lives. I understand maybe many of you are public health MPH students. This is what you're here for. This is the kind of thing that you want to do. You want to be able to understand the content. You want to understand the prevalence. You want to be able to do analysis. So, what do you do before beginning a surveillance activity? You need to address what questions are being asked. How infections or infectious diseases are defined. This is a critical piece here. If we all use different definitions, then what we end up doing is counting things that are different. Apples, oranges are not the same. You need to ensure that we follow a standard. Now, the data has to be collected, stored, retrieved, summarized, and interpreted. This is not a trivial thing. We have issues here in the kingdom with infrastructure, with resources, with actual organizational management. Many of the things that we found out when we were implementing Hessen was that many people do not follow the organizational standard that was laid out by His Excellency the Minister. Thank you. And so, as part of a project, you need to ensure that you maintain the integrity of a process, an organization, a change control system, and numerous things that have to be taken into account when you implement something that's nationwide, that's kingdom-wide. You're doing one hospital, it's a microcosm of that. But to do the entire kingdom, you've got to be able to understand all of the things that are occurring. Not just how the data is collected, but how it's saved, how it's stored, and how it's defined. Now you want to be able to feed the information back to your clinicians, to the frontline administrators, to the hospitals, to the sectors, to the regions. You don't necessarily have to deal with that here at the hospital, but we needed to look at how the data flows. We basically have public health centers, they're clinics, and we have hospitals in a catchment region, and those are actually maintained in a sector, and then the sectors report to the region, and the region to the national headquarters. So understanding how this flows, and if there's any problems with that organizational structure, how it needs to be altered to fit something. One of the big problems that you always have is when you get an application that is store-bought, or you get an application that's actually off the shelf, you end up with something that changes your process, because a lot of times it's easier to change the process than it is to change the application to fit it. And so this is why when you buy a large application, you need to ensure that it fits the infrastructure and the structure that you have with your data. And then, of course, you want to be able to use the data, the information, to bring about change. You want to see trends. You want to be able to benchmark this hospital against that hospital. We're doing a lot of JCI accreditation within the Ministry of Health. One of the requirements for JCI isn't for the initial accreditation that you have a benchmark. It's that you have the benchmark to compare something to 3 years later when you reaccredit. And you need a system that both follows JCI and other organizational requirements for this type of data, especially the definitions. And once you get this information, how can you bring about change? I taught a class in evidence-based medicine to Prince Sultan Military Medical City. I had maybe 250 nurses. I asked all of them, by a show of hands, who is going to be able to do the research, to do evidence-based process changing. Not one of them raised their hands. Not one. They're there for the CME, pure and simple. So, in order to affect change, we also need to understand how that information can bring change. How do you get that information a lot of the time? We'll talk about a little bit of that shortly. So the main aim of surveillance. You want to detect common sources of outbreaks. We've had a number of scenarios where things have occurred and we've found out about it too late, when it was very easy to get the information and gather it quickly and respond to it quickly. So the aim is to detect common sources of outbreaks. Our first priority is to look at the common type of infections in a hospital, the common type of infectious diseases in a particular region. Just as an example, if you have 5 cases of dengue fever in Jazan, 5 cases of dengue fever in Jeddah, and 5 cases of dengue fever in Riyadh, do you understand what the difference is? Can you make the call as to where there's a problem? I'll tell you, population, Jazan's small, Jeddah's middle, Riyadh's big. Is it a population question? It's not. This is where you talk about the common source. 5 cases of dengue fever in Riyadh is an outbreak, because we don't have dengue fever here. So this is the kinds of things that you need to understand. You need to identify the problem areas. You need to understand where they are, where the problems lie. We want a standardization of how we get the information. Infectious diseases has had standard forms for many years. And based on new definitions, they're changed, not frequently, but as often as they need to be. Infection control. We actually get our requirements for change from the GCC manual, who of course follows the WHO manual, who follows the CDC manual, and we need to determine what actually fits here in the kingdom. There are many things that are in those manuals that have no concept for the Middle Eastern region. So we want to be able to research to help the priorities for disease. The issue with what we're looking at is even in a hospital, if I know that during the month of November in this hospital I end up with 1,000 new cases of the flu, I can look at these trends and bring more doctors to bear during that time. If there's less, then we can actually schedule. So some of the predictive analysis that you can do for disease activities is built into this data. Now, we're also wanting to adhere to international as well as national standards. We're looking to benchmark. Our issue is that we can't benchmark against something, in Canada or in the U.S. or in South America, in Chile, Brazil, because we are totally different. We have different concepts, we have different methodologies. Most of them are the same in general, but they're specific to the needs here in the kingdom. So we need to understand those standards before we can actually do adherence policies for those. Now, we want to provide data to motivate clinicians. We want to provide data to take to management. We want to be able to go to stakeholders and deal with the concerns about infectious disease, deal with the concerns about infection control practices. If you end up seeing a particular piece of defective equipment that everyone is buying across the kingdom from the same vendor, then if we've got data, we can actually show that there's accidents occurring with the same equipment from the same vendor. We don't collect this kind of information, and we should, and we're heading in that direction. So again, the purpose of surveillance: reduce the incidence of disease and hospital-acquired infections, and thus reduce associated morbidity, mortality, and one of the key things in most places is costs. So, there are many types of surveillance. We've got the case-based, the syndromic, the early event detection, the sentinel surveillance. We've got case management, where you actually take it right out of the individual EHR, contact tracing, analysis, visualization, reporting, and alert functions that we build into our surveillance activities. The problem is that we need to understand how we get the information before we can do any of this. We can't do anything if we don't understand where the data comes from, how it's going to be used, how we're going to be able to analyze it. So, I'm going to just speak briefly on the e-health strategy. This is something that will be covered, I'm hoping, in detail by Keith and by Dr. Bacher later on. But this is the right out of the book. The Ministry of Health of the Kingdom of Saudi Arabia is committed to improving quality, access, and safety of the health system. And to this end, the mechanism for achieving this is a 5-year e-health roadmap. Now, the e-health strategy is an effort to bring to the entire Ministry of Health, the hospitals and the clinics, the ability to do e-health. That means they've got infrastructure for web, they've got infrastructure for doctors to look online to do additional diagnoses, and they've got the ability to share data. And so this type of infrastructure doesn't come easy. Many countries within the Middle East, many countries in Africa have no infrastructure. You may have the internet here, but you may not have the right to use certain portions of it or parts of it. I was at a hospital in Jeddah that their bandwidth was so low that they had to schedule different departments on different days to be able to use the internet. So this is problematic, and this is the kind of thing that they're going to be talking about as far as the history. So, again, from the e-health perspective, we're looking at a current state where everything is manual, unclear, inconsistent, as well as unstandardized and not documented. We have a ton of incomplete and missing data. We actually, and she probably doesn't want me to mention this, but we have the project manager of Hessen sitting in the back of the room. So hopefully she'll be up for questions later on. So what we want to get to, and we're working in this direction, is a clear, automated system where it's easy to use, well-defined, standards are used, and we have complete and accurate data. Now, let me tell you something about complete and accurate data. I'm a biostatistician. There is no such thing. What I look for, 95% confidence interval. If I can get there, then I've won. So we looked at tuberculosis, and tuberculosis was reporting 35% each month. And after doing some discussion, changing some personnel, adding some resources, and doing an evaluation here, we were successful at taking it to 90% in 2 weeks. So, surveillance, e-health, informatics. We're talking about an integrated surveillance and information system that allows rapid, correct, and complete collection, analysis, and dissemination of data of public health importance to people. We want those people involved who can take the appropriate action. It doesn't do any good to make a report and file it that nobody ever reads. And this is what happens a lot of the times. We want to be able to get this information in front of decision makers, in front of clinicians, in front of directors and deans, and in our case, the deputy and vice minister and His Excellency himself. We want them to see this information. We don't want it to be a punitive system. We don't want to punish anybody. We want the information so that we can evaluate and improve. We have a major training budget at MOH. We have a major budget to do the infrastructure. We've got a major budget to do HESN and to do the implementation. There's training going on right now across the kingdom. And ideally, it won't be long before they bring it to you as well, because it's not just going to be at the Ministry of Health hospitals. We want the entire kingdom to have access to this automated system. All right, so one of the things that we looked at as problematic, they brought me here to solve issues and problems. I've solved a number of them. Others will take time. But one of the things that we discovered was that if we want to get information now, we can't wait for the eHealth roadmap to take effect. We can't wait for the resources to be utilized, because many times, whatever our plan is, something else happens. We send IT money to a region, they end up using it on medicine and supplies. We actually attempt to do a number of upgrades, and we find out that STC or Mobily can't actually handle it because we're not on their priority. So, what we did was we found out that instead of just relying on web-based data, web-based systems, that we could actually get the data in a number of ways. So, we ended up implementing our form-based design so that you could use an iPad, an iPhone, an Android tablet. It doesn't work on a BlackBerry. Sorry. But it will work on a fax, because we have people who fax us information. My fax server actually takes that data right off of a fax and puts it right into the database using optical character recognition. The forms are, and I'll show you one of those later.